So now let's look at how we'll examine someone with carpal tunnel syndrome. So the first part, which is inspection, we look for any scars in the carpal tunnel area. So carpal tunnel incision usually would run from the distal wrist crease coming down in the middle of the palm up to this point. So we examine this area for any previous scars. We then look for the thenar eminence muscle bulk. So in severe carpal tunnel syndrome, there is loss of this muscle bulk and wasting of the muscle. So it's important to pick this up. And I'm going to compare it to the other side and see if there is any difference between the two. We then look for the area supplied by the median nerve to look for any skin changes. So the median nerve supplies sensation to the thumb, the index finger, the middle finger, and half of the ring finger usually. The ulnar half of the ring finger and the little finger are supplied by the ulnar nerve. If there is any problem here, in inspection you usually pick up a flexion of the finger, which is also called clawing. So you will pick up clawing of these fingers if there was any problem with the ulnar nerve. We'll also look from the dorsum, and in carpal tunnel syndrome we will not pick up anything on the dorsum of the hand, but if there is cubital tunnel syndrome, which is ulnar nerve problem, you can pick up wasting of muscles, especially the first dorsal interossei and other interossei muscles, leading to wasting of these. I then go on to sensation part, where we are checking for sensation again in the median distribution. So I compare both the sides and check for sensations in the tip of the thumb and ask if it feels the same or if there is any difference. We can also pick up a point on the forearm, which would be normal. So if someone has bilateral carpal tunnel, to compare and give them a control point, we use the forearm to check for sensation, and then we compare it on both the sides. So the thumb, tip of the index finger, middle finger, and also the ring finger. For checking the ulnar nerve, we would be checking for sensation on the tip of the little finger and comparing both the sides. If we turn the hands over, we can check for the third nerve in the hand, which is the radial nerve, which is the first web space on the dorsum of the hand, specifically the superficial branch of radial nerve. This will complete the sensations. The median nerve also has a motor part, which is the motor branch supplying the thenar eminence muscles. In inspection, we have seen for the muscle bulk. Now we'll check the power. So in this case, I would ask the patient to bring their thumb up and hold it in their position, and I'll push against it, 1, 2, 3. And in this case, you can see that he has good strength, and I can also feel the muscle contracting with my fingers. That's a normal test. He has normal power. If it was abnormal, you would be easily able to bring the thumb down, and you will also notice weakness and contraction of this muscle here. So that's for the motor power of the thumb in carpal tunnel syndrome. We then move on to special tests. The first one which we do is called a Tinel's test or Tinel's sign. We know the course of median nerve right in the middle of the wrist, underneath the palmaris longus tendon. So along that course, I will tap with my finger, and in a positive Tinel's test, patient will have electric shock-like feeling going down the distribution of median nerve. He will have discomfort and pain. That's a positive Tinel's test. The second test that we do is called the Phalen's test, where we would flex the wrists and keep them flexed for about a minute. What we are trying to find if there is any reproduction of tingling and pins and needles in the distribution of median nerve when we hold this position. That will be a positive Phalen's test for carpal tunnel. The third test that can be done is a Durkin's pressure test, where sustained pressure is applied over the carpal tunnel area either with your thumb or you can use your fingers, and we maintain this pressure for about 30 seconds. We are looking for any reproduction of symptoms, which is tingling and pins and needles in the median half of the hand. So those are the 3 tests that I routinely do in clinic. Whenever I examine anyone with carpal tunnel, I also examine the ulnar nerve for possible cubital tunnel, and here I'm feeling for the nerve behind the elbow on the medial aspect. It can easily be palpated in most of the cases, and any irritability around this nerve is a positive sign. We can do a Tinel's test, which is tap around the course of the ulnar nerve, and that will create tingling and pins and needles in the ring and little finger. And then finally, a provocative test is to flex the elbow fully and keep it flexed in that position for about 30 seconds to a minute, and this will again cause reproduction of pins and needles and tingling in the distribution of ulnar nerve, which is the little finger and half of the ring finger. We should also ask the patient about any problems with the neck to exclude any nerve root pathology which can mimic carpal or cubital tunnel syndrome. If we have any doubt in the diagnosis of any of these syndromes, we should get nerve conduction study tests, and that will confirm whether it's carpal tunnel or not. Thank you.